Welcome to the deep dive. We take complex topics, pull out what you really need to know, and, well, hopefully make it stick.
And maybe even have a bit of fun along the way.
Exactly. Today, we're zeroing in on the brain's ultimate control tower, the hypothalamus and the pituitary gland.
Tiny structures, massive impact.
Right. And for you, our bright medical students listening in, getting a handle on this dynamic duo isn't just, helpful. It's absolutely foundational.
It really is. It's central to how the body maintains balance, homeostasis, and what goes wrong when that balance gets knocked off course.
So our mission today, pretty straightforward. We want to simplify how they work, look at how they interact, which is fascinating, and give you the tools to spot when things aren't quite right.
We'll use clear explanations, some memorable details, and maybe post a few questions to get you thinking.
Okay, first things first. Anatomy. Let's start with the hypothalamus. The name itself gives us a clue, right?
It does. Hypo means under. Thalamus means room or chamber. So it's literally under the room of the thalamus, forming the floor and lower walls of the third ventricle.
Small but mighty. You called it the chief operating officer before.
Yeah, or maybe the emotional hub too. It's incredible what it regulates. We're talking temperature, heart rate, blood pressure, even emotional behavior.
Thirst, hunger.
Osmolarity, your body's fluid balance, goal-seeking behavior, the visceral nervous system, sexual activity, aggression. It's a long list.
And critically, it has these specialized neuroendocrine cells.
Exactly. Peptidergic neuroendocrine cells. That's the key link. They control endocrine function directly.
It's where drives meet hormones.
Okay, from the command center, let's move to its partner, the pituitary gland, also called the hypophysis. Where's this one hiding?
Well, it's pretty well protected, actually. It sits snugly in a little bony cavity called the sella turcica.
The Turkish saddle, I remember that.
That's it. Right in the sphenoid bone at the base of your skull.
Oh.
And it's linked to the hypothalamus by a stalk, the infundibulum, which is like a highway, you said.
Yeah, a superhighway for nerve fibers and blood vessels. Absolutely vital connection.
And the name pituitary? Something about mucus.
Yeah, bit of strange history there. Comes from the Latin for mucus. They once thought it channeled mucus to the nose. Obviously wrong.
Obviously. The Greek name hypophysis makes more sense.
Undergrowth, yeah.
Yeah.
Much more accurate. But here's a really key point for you to remember. The pituitary isn't just one thing.
Right. It's two glands fused together.
Exactly. Two distinct parts with different origins. First, the anterior pituitary, or adenohypophysis. Think A for anterior, A for adeno.
Okay.
This is a true gland. It actually grows up from ectodermal cells from Rathke's pouch during development, basically from the roof of the primitive mouth area.
So not brain tissue.
No, it's glandular tissue. Its job is making and secreting hormones, mostly what we call tropic hormones that target other glands.
Got it. And another part.
That's the posterior pituitary, or neurohypophysis. Think N for neuro. This one is nervous tissue. It's basically a direct extension down from the hypothalamus.
So it comes from the brain itself.
Precisely.
Yeah.
And critically, it doesn't synthesize hormones. It just stores and releases hormones that were actually made up in the hypothalamus.
Wow, okay. One part from the primitive pharynx, one from the brain. That's quite a difference.
It really is.
So here's a question for you listening. Given these totally different origins, how do you think the hypothalamus communicates with these two pituitary lobes? Is it the same way for both?
Hold that thought.
We'll come back to it because, as you said, that communication is key.
It's absolutely central. It forms the hypothalamic pituitary axis, the main coordinator, the endocrine highway connecting the nervous and endocrine systems.
Okay, so the answer to my question about communication.
Right. The answer is no. The communication is different, reflecting those origins we just talked about. For the posterior pituitary neural tissue, talking to neural tissue, it's a direct neurological connection.
Like sending a signal straight down a wire.
Pretty much. Hormones are made in hypothalamic neurons, travel down nerve axons through that infundibulum stalk, and get stored in the posterior pituitary, waiting for the signal to release.
Simple enough. But the anterior.
The anterior pituitary, the true gland, needs a different approach. It uses a specialized vascular connection.
Blood vessels.
Yes, but a very specific portal system. The hypothalamic hypophyseal portal system. Think of it like a private, a dedicated vascular hotline.
Okay.
Neurohormones are released from the hypothalamus, specifically the median eminence, into this portal system. These blood vessels carry them directly, a very short trip to the anterior pituitary cells.
Telling them what to do.
Exactly, telling those glandular cells which hormones to synthesize and release. It's an incredibly elegant system.
And this whole setup creates different axis.
Right. We categorize these multi-layered systems by their downstream target organs.
Mhm.
So you have the HPA axis, hypothalamic, pituitary, adrenal.
Stress response, cortisol.
Yep. Then the HPL axis, hypothalamic, pituitary, liver, involving growth hormone and IGF-1.
Got it.
The HPT axis for the thyroid, and the HPG axis for the gonads reproduction.
HPA, HPL, HPT, HPG. Okay.
Yeah.
And it's all regulated.
Oh, absolutely. By feedback loops. This is critical. The hypothalamus is constantly monitoring hormone levels from both the pituitary and the target organs further down the line.
Mostly negative feedback.
Mostly negative feedback, yes. It's like a thermostat. Too much hormone. The hypothalamus slows down production, not enough. It ramps it up. It integrates signals from the blood and from the nervous system, environmental cues, stress, etc.
A very sophisticated thermostat indeed. All right, let's meet the actual hormones, the messengers on this highway. Understanding these is, well, kind of the whole point for clinicians.
Absolutely. Let's start with the anterior pituitary's big hitters. We can call them the Tropic Six.
The Tropic Six, I like it. Okay, who's in the band?
Okay, first up, TSH, thyroid-stimulating hormone. Hypothalamus sends TRH, pituitary sends TSH, thyroid makes thyroid hormone, basically turns up your metabolism.
Got it. Next.
ACTH, adrenocorticotropic hormone. Hypothalamus sends CRH, pituitary sends ACTH, adrenals make glucocorticoids like cortisol. Think stress, immune function, glucose.
Okay, cortisol's big boss. Who else?
GH, growth hormone, stimulated by GHRH, inhibited by somatostatin. It affects pretty much all cells for growth and metabolism. Plus, it tells the liver to make IGF-1. That's a part of the HPL axis we mentioned.
Right. GH and IGF-1 work together there. What about reproduction?
That brings us to the gonadotrophins. FSH, follicle-stimulating hormone, and LH, luteinizing hormone. The hypothalamus releases GnRH and pulses, which triggers FSH and LH release.
Pulses are important there.
Very important. They target the gonads, controlling reproduction and stimulating sex hormone production, estrogen, progesterone, androgens.
Okay, that's 5. One more from the anterior 6.
The last one's a bit different. Prolactin. It's mostly inhibited by dopamine from the hypothalamus. Its main job is stimulating milk production in the breast, but it has other roles too.
Inhibited by dopamine. Okay, that's the Tropic 6 from the anterior pituitary. Now the stored 2 from the posterior.
Much simpler here. Remember, the posterior pituitary just stores and releases what the hypothalamus makes. The two are oxytocin.
Childbirth, breastfeeding.
Exactly. Uterine contractions, milk injection. And the other one is vasopressin, also known as ADH, antidiuretic hormone.
Antidiuretic, so it stops you peeing.
Essentially, yes. It conserves water, absolutely crucial for maintaining your fluid balance, sodium levels, blood pressure, basically kidney function, and overall hydration.
Okay, ADH for water balance. So, quick clinical thought for everyone listening. If a patient turns up severely dehydrated, which of those two posterior pituitary hormones, oxytocin or vasopressin ADH, would you expect to be working overtime? And what's its main goal?
Mull that over.
We'll circle back, but first let's touch on something else the hypothalamus does, beyond just hormone control via the pituitary.
Right, it wears many hats. Let's take fever as an example. It's a fascinating hypothalamic mechanism.
You mentioned the thermostat analogy earlier.
Exactly. The hypothalamus is the body's thermostat. When you get a fever, it's not broken. It's just been deliberately reset to a higher temperature.
How does that happen?
Well, it usually starts with things called pyrogens, often parts of bacteria, like endotoxins. These pyrogens stimulate your immune cells, like macrophages.
Okay.
These immune cells then release chemical signals called cytokines. These cytokines travel through the blood to the hypothalamus.
Tell it to turn up the heat.
Pretty much. They trigger the release of prostaglandins within the hypothalamus itself. And it's those prostaglandins that actually adjust the set point upwards. Result, fever.
Fascinating chain reaction. Okay, let's connect back to that dehydration question. Severely dehydrated patient, which hormone is high?
That would definitely be vasopressin or ADH. Its primary mission in that scenario is water conservation.
Makes sense.
It acts on the kidneys, telling them to reabsorb more water back into the body, helping to normalize blood osmolarity, sodium, and blood pressure. It's trying to stop you losing precious fluid. Got it. Okay, this is where the rubber meets the road clinically. What happens when these intricate systems, the control tower, the highway, the feedback loops go wrong?
This is absolutely key for diagnosis and management. Let's start with when things are too low. Hypopituitarism.
Meaning the pituitary isn't secreting enough hormones.
Or sometimes the problem originates in the hypothalamus, affecting pituitary release. It's relatively rare, thankfully. Usually it involves decreased secretion of one or more hormones. GH, FSH, and LH deficiencies are probably the most common.
What causes it?
A range of things, unfortunately. Tumors pressing on the gland, complications from surgery or radiotherapy nearby, infections, head trauma, and also ischemia, meaning lack of blood supply.
Ischemia, like Sheehan syndrome.
Exactly. Sheehan syndrome is a classic example: pituitary damage due to severe blood loss and shock during or after childbirth. The pituitary is vulnerable then.
And the symptoms reflect which hormones are missing. Precisely. It depends entirely on the deficiency. If it's gonadotropins, FSH-LH, you might see loss of libido. Women might lose periods, amenorrhea, or have irregular ones. Men might have erectile dysfunction, loss of secondary sexual hair in both.
Makes sense. What about GH?
GH deficiency causes growth failure in children. In adults, it's more subtle, maybe impaired strength, poor balance, just a general feeling of reduced well-being.
And TSH or ACTH deficiency?
TSH deficiency leads to secondary hypothyroidism. Think low blood pressure, weight gain, dry skin, feeling cold all the time. ACTH deficiency can cause mild low blood pressure, maybe low sodium, hyponatremia. And if prolactin is deficient, a woman won't be able to lactate after childbirth.
Let's try a quick case. Think about this. A 29-year-old woman, she had a baby 2 months ago after a very difficult birth with a lot of bleeding. Now she's struggling to breastfeed, feels incredibly tired, lightheaded, her heart rate is slow, blood pressure is low. What hormones might be involved here?
Okay, let's break that down. Struggling to breastfeed points immediately to low prolactin. Tiredness, lightheadedness, low heart rate, low blood pressure. That strongly suggests deficiencies in ACTH and probably TSH as well.
And given the history of difficult birth with blood loss.
It fits perfectly with Sheehan syndrome. Multiple anterior pituitary hormone deficiencies triggered by that postpartum hemorrhage and ischemia.
A really clear clinical picture when you connect the dots, but it's not always too little hormone, right? Sometimes it's too much.
Indeed. Pituitary tumors are another major category. Most are benign adenomas, but they can still cause significant problems.
Oh, so?
Two main ways. First, the mass effect. Just the physical size of the tumor pressing on nearby structures in that confined space.
Like the optic nerves.
Exactly. That can cause headaches and, very characteristically, visual field defects. The classic one is bilateral temporal hemianopia. You lose the outer half of your vision in both eyes. Think blinders on a horse. It can also press on cranial nerves, causing palsies.
Okay, mass effect. What's the second way?
The tumor itself might be functional, meaning it actively secretes hormones in excess. You can get prolactinomas, secreting prolactin, GH secreting tumors, ACTH secreting tumors.
But not all tumors secrete hormone.
Correct. About a third are non-secreting. They only cause problems via mass effect.
Okay, another quick case for you. A 46-year-old man comes in. He's got headaches, some visual problems. He also mentions that over the last couple of years, his wedding ring doesn't fit anymore, his shoe size has gone up, and he feels his face looks, quote, haggard. Exam confirms that bilateral temporal hemianopia. What hormone excess jumps to mind?
Ah, that's a textbook presentation. The changing ring and shoe size, the facial changes, combined with the headache and visual defect that screams growth hormone GH excess.
Leading to?
Well, it depends on when the excess starts. If it's in childhood, before the growth plates in the bones fuse, you get gigantism, proportional overgrowth.
But this guy is 46.
Right. So in adults, after the growth plates have fused, GH excess causes acromegaly. You don't get taller, but you get growth in other areas.
Like the hands and feet and jaw.
Exactly. Enlarged hands and feet. That's the ring and shoe size change. Coarsening facial features, prominent jaw, big supraorbital ridge. Also things like macroglossia, large tongue, skin darkening, maybe obstructive sleep apnea because the tissues in the throat enlarge.
Sounds quite distinctive.
It is. And it's not just cosmetic. Internal organs can enlarge too, impairing function. It's often associated with excess prolactin as well and can mess with glucose tolerance. So our case study patient likely has acromegaly from a GH-secreting pituitary adenoma.
Makes sense. What other hormone excesses are common?
Hyperprolactinemia, too much. Prolactin is quite common, often from a prolactinoma. In women, it typically causes periods to stop or become irregular, amenorrhea, oligomenorrhea, and infertility. In men, erectile dysfunction and maybe decreased facial hair.
And for both?
Both men and women might experience galactorrhea, that's milk discharge from the breasts when not breastfeeding, and reduced libido.
Okay. And the last big one is ACTH excess.
Yes, specifically Cushing's disease. This is when a pituitary adenoma, often quite small, a microadenoma, secretes too much ACTH.
Which then tells the adrenals
to plump out way too much cortisol. That leads to the classic signs of Cushing's weight gain, moon face, buffalo hump, thin skin, etc. We need to distinguish Cushing's disease, pituitary source, from Cushing's syndrome, which is just the state of high cortisol from any cause, like long-term steroid medication or an adrenal tumor itself.
That distinction seems crucial, which brings us back to feedback loops. Here's a vital clinical question for you listening. You have a patient with high cortisol. How do you use those feedback principles to figure out if the problem is an adrenal tumor churning out cortisol on its own or a pituitary tumor overproducing ACTH?
Excellent question. And understanding this is absolutely fundamental for diagnostic testing and endocrinology.
So how do you approach it?
Okay, think about the negative feedback. If you have an adrenal tumor making tons of cortisol independently, what does that high cortisol do upstream?
It should tell the hypothalamus and pituitary to shut down ACTH production.
Exactly. So you'll measure high cortisol levels, but the ACTH level in the blood will be suppressed, maybe even undetectable. High cortisol, low ACTH points strongly to an adrenal source.
Okay. And the other scenario, the pituitary tumor.
If a pituitary tumor is the culprit, it's autonomously secreting ACTH, ignoring the feedback signals. So it keeps pumping out ACTH. That ACTH then stimulates the adrenals to produce excess cortisol.
So you'd find
high cortisol levels along with inappropriately normal or, more likely, elevated ACTH levels. The ACTH shouldn't be high if the cortisol is high. So that mismatch tells you the pituitary is driving the process.
That makes perfect sense. It's all about whether the ACTH is appropriately suppressed or inappropriately high.
Precisely. And it also explains why giving someone external steroids, like prednisolone, suppresses their own HPA axis. The external steroid provides negative feedback, shutting down their natural CRH, ACTH, and cortisol production.
Right, which is why people need to taper off steroids slowly.
Right.
Okay, so we know how to think about these conditions. How do clinicians actually investigate and manage them?
Well, the investigation usually starts with blood tests, as we've discussed. Yeah. Measuring baseline levels of the key hormones. Prolactin, IGF-1 as a marker for GH activity, ACTH, cortisol, TSH, full thyroid function tests, TFTs, LH, FSH.
Sometimes baseline isn't enough.
Correct. Sometimes you need stimulation tests to see how the gland responds under pressure, assessing its reserve. The short synactin test, for example, checks the adrenal response to ACTH, or suppression tests for hormone excess.
And imaging.
Imaging is vital, especially if you suspect a tumor. An MRI of the head, specifically focusing on the pituitary region, is the gold standard for visualizing the pituitary and hypothalamus and looking for adenomas or other structural issues.
And once you have a diagnosis, what are the management options?
It really depends on the specific disorder. For pituitary tumors, the main options are surgery, often transsphenoidal going through the nose, radiotherapy, or medical therapy, with drugs designed to shrink the tumor or block hormone production action.
And for general hormone deficiency or excess?
If there's a hormonal deficiency, hypopituitarism, the treatment is typically lifelong hormone replacement therapy, giving back the hormones that are missing. For hormonal excess, medical therapy often aims to suppress the overproduction or block the hormone's effects. Sometimes surgery or radiotherapy is needed for the underlying cause, like removing the tumor.
It sounds like a complex but logical approach.
It is. It requires careful investigation and tailoring the treatment to the individual patient and their specific hormonal imbalance or tumor characteristics.
Well, we've covered a lot of ground today, from the basic anatomy right through to clinical disorders.
We really have. We've journeyed from the hypothalamus, that command post, down through the pituitary, its crucial partner, explored the intricate communication via the hypothalamic-pituitary axis, met the key hormone players, and seen what happens when things go wrong.
That link between the nervous system and the endocrine system, orchestrated by these tiny structures, is just incredible.
It truly underpins so much of our physiology.
And hopefully for everyone listening, especially our future clinicians, you've seen how understanding the details, the anatomy, the embryology, those vital feedback loops isn't just academic.
Not at all. It's the bedrock. It's how you'll decipher complex patient presentations and figure out the best way to help them.
Absolutely. So as we wrap up, here's a final thought to chew on. We've talked about hormones regulating things like growth, stress, metabolism, reproduction. But think about the timing, the pulsatility of GnRH, the diurnal rhythm of cortisol. How might the precise timing and responsiveness of this access to environmental cues, things like light, sleep, stress, even seasons, subtly shape not just our physical health, but maybe even our behavior, our mood, our susceptibility to certain conditions over time?
That's a great question. What other deeper influences might these tiny glands be exerting that we're only just beginning to fully appreciate?
Something to ponder as you continue your journey. Thanks for joining us on this deep dive.